Cirrhosis. Cirrhosis represents severe chronic injury to liver with diffuse disruption of the hepatic architecture. Cirrhosis represents severe chronic injury to the liver with diffuse disruption of the hepatic architecture. Cirrhosis represents severe chronic injury to the liver with diffuse disruption of the hepatic architecture. Etiology: alcoholic cirrhosis, nutritional cirrhosis और लेनिक cirrhosis. अल्कोहल के कारण हो सकता है, दैट इज अल्कोहलिक सिरहोसिस, न्यूट्रिशनल सिरहोसिस और लेनिक सिरहोसिस. पोस्ट नेक्रोटिक सिरहोसिस और पोस्ट हेपेटिक सिरहोसिस. पोस्ट नेक्रोटिक सिरहोसिस और पोस्ट हेपेटिक सिरहोसिस बिकॉज ऑफ क्रॉनिक हेपेटाइटिस बी एंड क्रॉनिक हेपेटाइटिस सी के कारण पोस्ट हेपेटाइटिक सिरहोसिस हो सकता है. बिलियरी सिरहोसिस, pigment cirrhosis and hemochromatosis. Pigment cirrhosis and hemochromatosis. Cirrhosis and Wilson's disease. Cirrhosis and alpha-1 antitrypsin deficiency. Cirrhosis in autoimmune hepatitis. Cirrhosis and Wilson disease. Cirrhosis and alpha-1 antitrypsin deficiency. Cirrhosis in autoimmune hepatitis. Cirrhosis and non-alcoholic fatty liver disease. Cirrhosis and autoimmune hepatitis. Cirrhosis and Wilson's disease. Indian childhood cirrhosis and cryptogenic cirrhosis. So cirrhosis represents severe chronic injury to the liver with diffuse disruption of the hepatic architecture. Etiology: alcoholic cirrhosis, nutritional cirrhosis or लेनिक cirrhosis. Post necrotic cirrhosis, post hepatic cirrhosis because of chronic hepatitis B and chronic hepatitis C infection. Biliary cirrhosis, pigment cirrhosis and hemochromatosis. Cirrhosis in Wilson disease. Cirrhosis and alpha-1 antitrypsin deficiency. Cirrhosis and autoimmune hepatitis. Cirrhosis and non-alcoholic fatty liver disease. Pigment cirrhosis and hemochromatosis. Cirrhosis and Wilson disease. Cirrhosis and alpha-1 antitrypsin deficiency. Cirrhosis and autoimmune hepatitis. Cirrhosis and non-alcoholic fatty liver disease. Indian childhood cirrhosis. Cryptogenic cirrhosis. Pathogenesis of cirrhosis: loss of hepatocytes with injury either by necrosis or apoptosis. There is loss of hepatocytes with injury. The loss of hepatocytes is either by apoptosis or necrosis. Restoration of the lost parenchyma by regeneration. Restoration of the lost parenchyma by regeneration. The lost parenchyma is restored with regeneration. Proliferation of the residual cells or by stem cell activation and differentiation of the hepatocytes. Proliferation of the residual cells, stem cell activation and differentiation to hepatocytes. Restoration of the lost parenchyma by regeneration. Proliferation of the residual cells and stem cell activation and differentiation to hepatocytes. Stem cell differentiation and stem cell activation and differentiation to hepatocytes. Scarring with fibrosis mediated by myofibroblast. Scarring with fibrosis mediated by myofibroblast derived from stellate cells with the role of PDGF, TGF-beta, interleukin 1 and TNF. Scarring with fibrosis mediated by myofibroblast derived from the stellate cells with role of interleukin 1, PDGF, TGF-beta and TNF. Vascular derangement and vascular shunting due to smooth muscle contraction of blood vessels, contraction of the myofibroblast and compression of sinusoids. vascular derangement and vascular shunting. Vascular derangement and vascular shunting due to smooth muscle contraction of the blood vessels. Vascular derangement and vascular shunting. Vascular derangement and vascular shunting due to smooth muscle contraction of the blood vessels, due to contraction of myofibroblast and compression of sinusoids. Vascular derangement and vascular shunting. Vascular derangement and vascular shunting due to smooth muscle contraction of blood vessels, due to smooth muscle contraction of blood vessels, contraction of the myofibroblast and compression of sinusoids. Morphology. Gross morphology. Surface of liver appears with nodules of varying size. Surface of liver appears with nodules of varying size. Morphological classification. Micronodular cirrhosis has nodules less than 3 mm in diameter. Micronodular cirrhosis has nodules less than 3 mm in diameter. Example, alcoholic cirrhosis. Macronodular cirrhosis has nodules greater than 3 mm in diameter. Example, post-necrotic cirrhosis. Mixed cirrhosis. Both micronodular and macronodular patterns are seen. Gray-brown nodules are separated from one another. Gray-brown nodules are separated from one another by gray-white fibrous septa. Gray-brown nodules. The nodules are gray-brown in color. They are separated from each other by gray-white fibrous septa. Microscopy. Regenerative parenchymal nodules surrounded by fibrous bands and a variable degree of vascular shunting. Regenerative parenchymal nodules. Regenerative parenchymal nodules surrounded by fibrous bands and a variable degree of vascular shunting. Regenerative parenchymal nodules surrounded by fibrous band and a variable degree of vascular shunting. Morphology of alcoholic cirrhosis. Gross. Initially, liver appears enlarged and fatty with micronodular cirrhosis. Initially, the liver appears enlarged and fatty with micronodular cirrhosis, but later it shrinks and becomes non-fatty with macronodular cirrhosis. Later, the liver shrinks and becomes non-fatty with macronodular cirrhosis. Microscopy. Fibrous septa surround the regenerating parenchymal nodules. Fibrous septa surrounds the regenerating parenchymal nodules and extend from central vein to portal regions. Fibrous septa surround the regenerating parenchymal nodules. Fibrous septa will surround the regenerating parenchymal nodule and extend from central vein to portal region, from central vein to portal region, from central vein to portal region, or portal tract to portal tract, or both, from central vein to portal region or portal tract to portal tract, or both. The hepatic parenchyma within the nodules show extensive fatty changes early in the disease. The hepatic parenchyma within the nodules show extensive fatty changes early in the disease, but are greatly reduced in the advanced disease. The fibrous septa usually contains sparse infiltrate of mononuclear cells with some bile duct proliferation. The fibrous septa usually contains sparse infiltrate of mononuclear cells. Fibrous septa usually contain sparse infiltrate of mononuclear cells. The fibrous septa contains sparse infiltrate of mononuclear cells with some bile duct proliferation. Morphology of post-cirrhotic Post-necrotic cirrhosis. Gross appearance: the liver appears small and shrunken, having distorted shape. The liver appears small and shrunken, having distorted shape, with irregular and coarse scars and nodules of varying size. The liver appears small and shrunken, having distorted shape, with irregular and coarse scars. Distorted shape, irregular and coarse scars, and nodules of varying size. Microscopy: thick fibrous septa surrounding the regenerating parenchymal nodules. The fibrous septa surrounding the regenerating parenchymal nodules contain prominent mononuclear inflammatory cell infiltrate, and often there is extensive proliferation of bile ductules. Often there is extensive proliferation of the bile ductules. Liver cells vary considerably in size, and multiple large nuclei are common in regenerative nodules. Liver cells vary considerably in size, and multiple large nuclei are common in regenerative nodule. Liver cells vary considerably in size. Liver cells vary considerably in size, and multiple large nuclei are common in the regenerative nodule. Fatty change may or may not be present in the hepatocytes. Clinical presentations can be asymptomatic. Non-specific manifestations such as anorexia, weight loss, and weakness. Non-specific manifestations like anorexia, weight loss, and weakness. Jaundice with pruritus, encephalopathy, and coagulopathy. Jaundice with pruritus, encephalopathy, and coagulopathy. Jaundice with pruritus, encephalopathy, and coagulopathy. Palmar erythema and spider angiomas of skin in male. Spider angiomas of skin in male. Palmar erythema, and spider angiomas in the skin of males. Hypogonadism and gynecomastia in males. Hypogonadism and gynecomastia in males. Complication: portal hypertension with clinical consequences, ascites. Portal hypertension, ascites. Portosystemic shunts manifest as hemorrhoids. Portosystemic shunt manifest as hemorrhoids, esophageal varices, and caput medusa. Post-systemic shunt manifest as hemorrhoids, esophageal varices, and caput medusa. Congestive splenomegaly with hypersplenism may cause pancytopenia. Congestive splenomegaly with hypersplenism may cause pancytopenia. Hepatic encephalopathy, and the other complication can be hepatocellular carcinoma. Cause of death: hepatic encephalopathy, bleeding from esophageal varices, bacterial infection, and hepatocellular carcinoma. Cause of death: hepatic encephalopathy, bleeding from the esophageal varices, bacterial infections, and hepatocellular carcinoma.